talking about the communication. We know that how much ever we learn in communication, it's still not enough. We need to improve our skills during our clinical practice in palliative care. So Dr. Tom is an associate professor of pediatrics at University of California, San Francisco. His clinical practice includes both palliative care and rehabilitation, and he has done his fellowship from UCSF in hospice and palliative medicine, and he has been in practice for the last 6 years. His interests include education and physical wellness. And thank you so much, Tom. This is a weekend and early morning. So happy that you agreed to be a part of this program. And we have a bunch of enthusiastic learners here. Most of them are in palliative care. And these are people who really want to learn more and improve the clinical practice. So personally, I like this learning group because they interact and they are here to learn on their own, for their own. So thank you so much for being a part of this program. Welcome you.
Thank you so much. Thank you for that very kind introduction and for the wonderful invitation. I will acknowledge it's a little early in the morning. You're the first people I've spoken to, so my voice may be a little froggy for a few minutes. I hope you'll indulge me in that. And it's lovely to see you all virtually over the screens around the world. I'm going to start by sharing my screen, and we'll get to this. I have to tell you that just now I was opening up my computer and I couldn't find this PowerPoint that I was working on, and I had this moment of thinking, wow, what would it be like if I started a presentation and didn't have my slides? And I've been a teacher now since 1985. The first time I taught a class was in 1985, so it's been almost 40 years. And I have had to improvise on occasion, but I think this would have been a particularly challenging one to improvise with. And then at the same time, I'm not sure it really would be, because I'm guessing that there is enough combined wisdom and experience in this virtual room that many of the things like I'm going to say we could generate on our own. And so what I may do is quite a bit of, I've got some structure in the slides ahead, but I may stop and just sort of ask you questions and have us discuss things as a group, either into the chat box or have you unmute and add your insights. I really would like this to be as much of an exchange as possible. That's my preferred way of teaching. A little more difficult to do in Zoom, but I really welcome your comments, and just feel free to chime into the room. So let me go back and just before I'm going the wrong way already. There we go. So I chose the title "Our Scalpel" for communication palliative care because of the slide that I just showed you a moment ago, and you'll see, we'll read it together. To talk about how in palliative care, Dr. Eric Cassell, who was a wonderful man, palliative care and internal medicine physician in Boston. And as you can see, he wrote, similar to scalpels for surgeons, words are the palliative care clinician's greatest tools. Surgeons learn to use their tools with extreme precision because any error can be devastating. So too should clinicians who rely on words. Now, that's a dramatic statement. I'm not sure I entirely agree with this. I mean, we can certainly do harm with our words, that's clear. But I think there's also great opportunity to do repair with our words as well if we misspeak or if we misstate something. And that repair actually could be at a meta level, an opportunity for a greater development of a therapeutic relationship. So the objectives for this time are to review some fundamentals of communication in palliative encounters, share best practices, and love again to hear what works well for you and your practices right now. Talk for a while about recognizing and responding to emotional content. And then I did a literature search, and I would not characterize this at all as comprehensive or complete, but it was interesting to me. I just wanted to look at some of the recent literature, and particularly some things I thought were of interest related to some general topics of communication that have come up in the last 2 to 3 years. So let's start with a little bit of sharing. And for those of you who are movie fans, I don't know if you know the reference of the picture here. It's this Cool Hand Luke with Paul Newman there in the foreground and Strother Martin in the background. And Strother Martin very famously says, "What we've got here is a failure to communicate." And I'm curious about what are the challenges that you have faced in communication in palliative care. What have been the tough situations, if it's a specific situation, or more generally, is there a time that feels particularly challenging? And again, if you want to unmute and speak into the room, that's fine. Or if you'd like to write into the chat box, let's take a couple moments to share our experiences with this.
Good evening, sir. In my practice, am I audible, sir?
Yes, you are. Thank you very much.
Yes.
Yeah, I find breaking the news that now nothing more can be done. I mean, this is the end of treatment. I mean, that becomes very difficult. That now that we can't do anything more on this. We can just make you comfortable. I mean, we are not still so used to communicating this. And in India, it's very common that the relatives generally they don't say the patient about that now nothing can be. They want to keep it among themselves. So when we want to, even if we want to say to the patient, the relatives don't allow us. I had like 2-3 experiences like this. So I want to say to the patient that what do you know about your disease? How much do you know? So the relatives they try to stop us. They say no, don't say anything to the patient. That becomes very difficult for us.
So when you're eliciting a patient's understanding, it's difficult to get. They may not have very much understanding because they may not have been told very much. And then it sounds like also being in the position of having to say, there are no more curative options available for us. And so our focus of care is going to be shifting right now, can be difficult. And that can feel a little bit like you're, as the clinician, abandoned without opportunities for intervening for a patient. So thank you very much. Yeah. And was there more to say? I didn't want to cut you off.
Tom, there are a few chats on the same topic. Are you able to read the chats also, or do you want me to?
Yeah, I can see them here. Actually, these are wonderful. Thank you all very much. So I noticed Dr. Srilata saying breaking bad news. And I did not do particular slides on that, but we can take some time and talk about that. There's a little bit in what we're going to talk about here. In fact, there's a great resource that I'll be talking about, which is called Vital Tips, which has some really nice guidelines and suggestions for folks. Are you familiar with Vital Tips, the app? It's a phone app. So Vital Tips, Vital Talk, we'll talk about, is a system, an education system for communication that was put together here by a colleague up in the Washington State area north of here, and others across the country. And Vital Tips is the app, and we'll see that in a moment. Patients not being in a position for active listening due to pain or suffering. And yeah, the limitations in communicating with someone who is in such significant pain that they cannot even think straight, let alone find the right words. Dr. Babu, end of life care talk. And I will echo that. I find that particularly challenging because I do pediatric palliative care solely, and that's a very difficult thing to walk through with a parent and a child. A silent patient, a patient who is not ready to speak or not willing to come forward. When you have to talk to very young people, parents don't want to share their prognosis. Absolutely. And parents don't wanting to protect the child, this idea of mutual pretense. Is that a concept? I don't know if this is familiar, this idea that both sides are pretending that the thing that's happening isn't happening in order to protect one another. So the parents don't talk about death, and the child may not talk about their imminent death, or a young person may not talk about their imminent death because they don't want to, they're pretending again to protect one another. It's a very exquisite kind of love, and also a difficult place to navigate as a clinician. When a patient is not in a position to accept the bad news, we feel it's necessary to share it to the patient. Time constraint, absolutely. It's very difficult when you're trying to see a lot of patients and don't have the option. So I believe Dr. Sudhakaran has raised his hand and be happy to hear your comments, and then we'll come back to the chat box.
Hi there. So I just want to bring out a point in the Indian scenario. Many a times we end up treating the family instead of treating the patient. And in this, there is a fine. It's a gray zone. It's a razor's blade which we are walking on. You have to say something which will not offend the family. At the same time, out of our concern for the care receiver, we want to say something which may be of use for him, for the patient as such. So navigating that gray zone, where are we treating the patient or are we treating the family? What to talk to whom is something which is often challenging in the Indian scenario.
Exactly, because I think you point out something really important, which is none of us exists without a context, especially if we have close family members. And so if my care is directed towards one person and I ignore the other folks in the room, I may be missing something really important and actually doing some unintentional harm. So that's, thank you very much. It's a great comment. There are such great comments in the chat box here. I'm going to continue on. And again, if you would like to speak into the room, please raise your hand, or otherwise just unmuting is also fine. While giving multiple options, I find it difficult prioritizing which option to give first, maybe due to lack of in-depth knowledge. And that one also resonates with me too. If you're giving options, which is the one? And I think we can talk a little bit about making recommendations that ideally reflect what are the patient's values, which you have hopefully elicited earlier in the conversation. Administering a pain scale to an illiterate person. And I am curious, do you all have the FACES scale that, or is this a familiar concept? So we often will say, the 0 to 10 scale, 10 being the most severe pain imaginable. But again, in pediatrics, we have a lot of kids who don't have the ability to speak, or may not have a conceptual idea of setting a number to a pain. So we'll use a scale that is a set of faces, with a relaxed face and more tense face, and then the child can point at which one looks like them. Then, of course, you can use this for adults as well. Is that a familiar thing? I'm looking at faces to see if there are any nods. But I can't see for sure. If so, please put it into the chat box. I'd be curious to see. Using words positively, antagonism from the patient. That's also a very difficult one when a patient is angry. And we'll talk about responding to emotions like anger, fear, and hurt. And then this is a wonderful comment too. Sometimes patients and families keep talking about a miracle happening and not talking or making decisions at the end of life. It's like a roadblock. I think you're absolutely right. Of course, a miracle it's a protective thing in this situation, because so long as you're focused on the miracle, the other thing isn't going to happen. And we can talk a little bit about second hopes. I didn't include a slide in there, but Sri Devi, if you would remind me, I will. Well, let's come back and talk about second hopes. I'm just going to make a note for myself, because that can be a really helpful technique to use in these situations. Okay. Before we go on to the next slide, any other comments? I see. Okay, someone said they've learned about the FACES scale, but not using it here. I think if you're in that situation, you can probably, if you have access to a printer, find it online and just print one out, or potentially have it on a phone and just show a picture of it. I can look at my cell phone in a second, see if it's possible to get one. But, okay. So why do we focus on communication? for me, this is about getting at the power of the stories we tell and about the stories we tell about ourselves. When we write stories, create narratives, when we tell ourselves stories within our own minds, we're making meaning out of our life. We're making meaning about who we are and who the people around us mean to us as well. And so our ability to find out what the story is that one is telling about themselves or about their illness or about the people around them allows us to open up the world inside of them that we can hopefully then access to navigate with them through the most difficult moments of their life. And when I wrote, this is close to my heart because when I wrote my essay to get into fellowship, this is one of the things I talked about was the question of a medical story, which is a very powerful idea. Some people call them illness scripts. The idea that when this is what we get trained as clinicians, we get trained to understand a set of facts and we put it into a narrative structure that's really a story about an illness. This patient, the facts are that they had a fever and they had shortness of breath, and then they're having have had difficulties with swallowing, for example, maybe they're post-stroke. So we put that in together as a story of aspiration pneumonia, and then we have a plan that's sort of implicit in that story. And that's a very powerful story. And we impose these illness scripts onto patients, but in imposing them, we run the risk of losing the story of who they are behind it. And that's where very exquisite and careful communication could be so important. And as I said a moment ago, aligning their personal goals and wishes with care, with treatment plans. Excuse me. I forgot to say also, I'm just about 10 days out from recovering from COVID. And so I'm a little bit froggy in the morning with that as well. So again, your forbearance is greatly appreciated. And the final thing I do want to spend a little time with this last bullet point, which is that we will come into rooms with assumptions and we may have hypotheses. I had a fantastic mentor when I was working up in Seattle, a man named Stu Farber, who was one of the folks who really helped get palliative care started around the United States, and particularly at the University of Washington. And he used to talk a lot about having hypotheses about an emotional state or a decision-making state, and then testing those hypotheses through asking the right questions and through an openness and willingness to cultivate a relationship with the patient. And you can say, I can imagine that you're feeling sad right now, or I can imagine that you're trying to choose between something that gets you as much life as possible, but also allows you to be home more in the near term. And that's a way, and then you can confirm that hypothesis with questioning. I'd like to take a moment to talk about our ability to cultivate a capacity for connection. And I think this is important, especially in those moments when you don't have a lot of time, that relying on our ability, ourselves as clinicians, to come to our own grounded, centered presence, where we are open, we are feeling compassion, and also an equanimity, an ability to accept a lot of different possibilities, and bringing that centered presence into a patient encounter or patient and family encounter is extremely important. And that openness and that capacity for connection allows for us to connect and communicate most effectively. I like very much, and I think all the time, actually, many times over the course of the day, of this idea of a strong back and a soft front. And I learned this at a fantastic course in New Mexico that I went to. It's been 3 years now, I think, with Roshi Joan Halifax and a number of other wonderful teachers. It's called Being with Dying, and it's at the Upaya Zen Center there in New Mexico, here in the States. And one of the things they talk to us about is this idea of cultivating a strong back and a soft front. And our strong back is our strong back of equanimity. It's a sense that our spines are firm and that we are centered and stable in the moment. The soft front is the soft front of compassion. Roshi Jung calls that quivering in our heart when we come and encounter another person's suffering, and we feel that impulse to care for them, to relieve their suffering. And so to maintain the balance between the strength of our strong back and also the softness and tenderness of the soft front is the goal of walking into a patient encounter. You obviously don't want to do the reverse. And sometimes those things can happen. We can get a sort of weak back, and sometimes that can be because we're too fixated on one outcome or another. And then a very harsh front can be counterproductive as well. Okay. Well, actually, I'm just curious about this, and I think this is as much for my own edification, but I'm curious, and sometimes in some of the chat box comments that were made earlier, there was a sense of families not being receptive or not being open. When you're introducing palliative care to a patient, if you're coming to see someone for the first time or you're talking to a colleague who doesn't know it very well, what kind of words do you use to describe it? And the reason I bring this up, I hope is clear, but I'll just say explicitly, is because part of what makes success is what the expectations are on both sides of the conversation. So what do you say to introduce palliative care when you first come in to see a patient or see a colleague? And again, if you'd like to unmute or into the chat box, that's fine.
May I?
Please, please.
So I think the first thing which I ask is, how did you end up reaching here, and what do you expect from us? Is something which will be an opener, so that we get an idea as to what is their insight on the kind of services which we provide. And once we understand where they stand, probably from there, we can take it ahead. Most of the times it is like, we may not be able to do something about the disease, but whatever are the symptoms which is causing distress to the person, we are here to address that, so that he or she can be as comfortable as possible.
Thank you. Thank you. That's great. I appreciate it. Looks like there's a comment in the chat box as well. Yes, making you comfortable. Yeah. Oh, that's Sri Devi. Thank you. Thank you. And Dr. Punita introduced the concept of conservative care, supportive care. Yeah, we often use the word supportive care as well. Tell them directly as palliative care. Meant to make the patient comfortable and also support the caregivers and family. Absolutely. Don't ask leading questions. As a palliative care physician, how we can support them in the course of illness from diagnosis till final stages. People who will address your sufferings and help you. And thank you very much as the radiation oncologist. I'm sorry, let me get your name. These comments are coming in quickly. Dr. Vasant, Dr. Christopher Vasant, thank you for paving the way for us as we come in as specialists. It's extremely helpful. We're here to negotiate the journey from no disease-directed therapy to end of life alongside your family. And they're excellent, wonderful. Oh, we're getting so many good responses. Try to tell them that we want to journey with them. And I noticed that, again, using the word journey there. Once the patient is comfortable, ask how much does he know about his disease, and whatever will be the course, I will be with them. And I think that's so important, Dr. Venugopal, to say that, make the promise and be available to be with folks. I think there's often a fear of abandonment, especially with life-limiting illness. Extra layer of support, simultaneously with curative treatment is very helpful too, and through information support, symptom control, decision-making, and even end-of-life care. Great, thank you all very much. I'm going to share the few thoughts that I have on my slide, which are not nearly as many as you just given to me. I do tend to ask about prior experiences, and let me say, especially for pediatric palliative care, which is what I primarily do, if a family has had an experience with another adult member who's had palliative care or who may have died under the palliative care or hospice care, then they may have a different view of what pediatric palliative care could be. So I ask about, have you ever heard of palliative care before? Is this a new concept for you? What have you heard about it? And then I, as many of you did, offer a brief explanation of your team. We're a consulting team for people who are facing serious illness, I think is a nice way of putting it. Our team addresses physical, emotional, spiritual suffering. And I will often, in introducing that, if I'm in there with my team members, because I work with chaplains and social workers, and I have actually a child life specialist. I'm very, very pleased to say we also have a therapy dog who works with us at one of the hospitals, and that's an extraordinary thing to have a dog come into the room for you. It's a great way of getting to children and families. If you're the team with the dog, people are happy to see you. And often people will use the idea of the extra layer of support. So these are some pearls that, again, I think we could elicit these from the group. If I were to put these out there, what are the things that are helpful for you? This is a partial list. And if you're seeing something there that jogs your memory of something you'd like to share with the group, please write into the chat box. I am, especially working with trainees for the first time, I always want to remind them about the idea of ask, ask, ask. There's so much information we get from asking, from hearing the story of the patient, from hearing what they know. And one of the bullets I should have put on here that I did not do is silence, and how important our ability to sit with silence is, to be comfortable with silence, to recognize that silence doesn't mean that there is nothing going on. There's often a lot going on inside of a patient's mind or heart, and our ability to sit with that silence is extraordinarily important. There have been some studies showing that the average time that a clinician waits for a patient to speak is about 7 seconds. I know for myself, if I were facing a life-limiting or a life-ending diagnosis, that I would be doing a lot of internal work, and I might need 20, 30, 60, 90 seconds to think through, to even to, if I had a wave of powerful emotion, to let that wave pass before I'd be able to fully communicate. So our ability to be comfortable with silence is important. Again, reminding ourselves about using open-ended questions, which I realize is a basic palliative care skill. What have you been told about your illness? Or asking a family member, how do you think they're doing? I like using the idea of, especially this is really important in kids, but not exclusively with kids. If you've been on a treatment pathway and now you've reached a juncture, and so for example, when the family was talking about miracles, when you have a family that's talking about miracles, one thing to say is we're also hoping for that miracle. I think we're in a different place right now, and we may be needing to think about other possibilities. And let's go through the rest of these, and then actually maybe this will be a good time to talk about second hopes. Both expressions, I wonder and I worry, as a way of introducing ideas or introducing uncertainty or potentially negative news, are effective short little phrases. Wonder, if I wonder, I'm exploring possibilities. I'm leaving open. I'm not saying this is what's going to happen. I'm not saying that I know for sure. I'm thinking about, I wonder if this approach might be more helpful for you. I wonder if you may be feeling these things. And that openness, that kind of questioning that you're modeling in yourself can be really powerful as an opportunity for folks to wonder too about what is happening in their bodies and in their spirits. I worry, I think, is also a very effective phrase to use here. I worry. because it reflects not only concern, but also an emotional content in it. So if I say you have progression of your disease, that's a statement of a fact. I worry that your disease is getting worse says that I'm having my own emotional response to this, and I want to share that with you, and it allows us to connect in a different way. The third person technique, which is to take a person's, this is like the hypothesizing, you take an idea that you think someone may have, project it onto someone else. So many people in this situation may feel that this was all over and that they would be done with their treatment. Have you had feelings like that? And again, it allows that triangulation, that allows it to be discussed a little more differently. And then normalizing is a very helpful thing to do. That's a common thought. Many people say things like this. And I can say actually from my experience just recently of having had COVID, this was not life-threatening by any means, but there was uncertainty connected to it. And I found that when I talked to other folks and sort of heard from them that they had had a similar experience, similar symptom experience, similar worries, that there was some solace in that. So let's talk a little bit about second hopes, the idea of second hopes. And there's a kind of a script for establishing second hopes. Is this a new idea for you, or is this something that you have heard before? Sri Devi, do you know if it's as
Sorry, you want me to?
I'm curious if the idea of second hopes is new to this group.
Yes, I'm hearing it for the first time.
Okay, great. Okay, thank you. So the idea of second hopes is that, let's say you have a patient who comes to you and you say, what are you hoping for? And given that, all the things that you've heard about your illness, what are you hoping for? And say, we're hoping for a miracle. We're hoping that some sort of divine intervention will happen, and we know this deep in our hearts that it's going to happen, and we've been praying for it. So what I do is really kind of 3 steps. So the first thing I will say is, in response to that, is I am hoping for that miracle with you as well. That it's deeply in my heart. I hope it happens. And I really do try to deeply believe that and reflect that belief with the family in that moment. Even if my medical understanding is that there's no chance of a miracle, there's no chance. I mean, we don't ever really know everything with absolute certainty, but if everything is pointing towards this not being possible for a miracle to happen, I still do my best to align with the family and say, yes, I'm hoping for that miracle with you. Then the next step is say, if that miracle is not possible, is there anything else that you're hoping for? Or what else might you be hoping for? And so what I've done there is align, and then I've offered the possibility. I'm not saying it's not going to happen. Say, if this is not possible, and then open up. So the third thing is, the first is to align. The second is to say there's a possibility the miracle might happen. And then the third thing is to open up for what else might you be hoping for. And that's what the second hopes can bring. And this can be very poignant with children, because of course parents are very, very invested in their children living as long as possible. If their child is not going to live, and you give them the opportunity to sort of explore the space where their child wouldn't live, what's important for you? Well, it's really important that they be home with their brother or sister. It would be great if we could have them well enough so that they could visit with their grandparents again. They love to go on this kind of outing. Maybe we can make that happen. Whatever those second hopes can be, then we can open up a possibility of another pathway that doesn't involve a miracle. Now, it is possible that someone will come back and say, I don't have any other hopes. The only thing I'm focused on is a miracle. And that can be a difficult situation. And I'm not going to be able, I don't think, to completely unpack that. But I do think that asking also about the miracle, what does a miracle mean? And that's where I often would involve a chaplain too, because I feel like a chaplain can ask the questions like, well, maybe is it possible that God has a different kind of miracle in mind than what we're thinking about here too. Noticing there are a couple of comments in the chat. So, okay.
Yeah, I think it was about second hopes. It's new to most of them. That's
great. Okay. So I hope that's a helpful thing to use. So again, the second hopes, and remember the three parts. So first of all, aligning and really aligning with authenticity in yourself. Secondly, offering, if that's not possible, then what else might you be hoping for? And continuing to ask again, is there anything else you might be hoping for if it's not possible? And giving opportunity for a few things to unfold. So I mentioned this earlier. I'm really just keeping an eye on time too, to Sridevi, you'll let me know as well. So Vital Talk training courses, Vital Tips, Fast Facts, Jerry Talk, and excuse me, in the States, we have CAPC resources. I think IAPCON will probably have some things as well in India. Vital Talk is our sort of main framework for teaching communication skills in the States. They do, I believe, online courses that can be taken remotely. They're very, very effective. There's a lot of work that's been done in generating these. And I'll show you a screen grab from Vital Tips in just over the next couple slides. Fast Facts, I'm not sure if you're familiar with this. This is also available as an app and was put together by the CAPC group, which is the Center for the Advancement of Palliative Care. Fast Facts is available as an app, and you can search for topics. So how to do a family meeting, how to deliver bad news, how to navigate advanced care planning with a non-responsive patient and family members. So those are all very helpful. I'm going to show you a couple of screen grabs here of the Vital Tips app. So when you open up Vital Tips, and you'll get on the left this screen here, and I split the menu a little bit. So this is not a complete menu, but you see the top 5 here are COVID related. The bottom 5 are the kind of standard things that have been in this app for a long time. So responding to emotions, serious news, prognosis. So I chose to, just for the purposes of this talk, to go to serious news. So when you click on serious news, you get this next screen, and it has the guide talking map. Get ready, understand, inform, deepen, and equip. And then as you click to the next page, it'll do the get ready part. So then you're know what the news means, invite important people, find a place that's quiet, and sit down. So they just remind you of all those things. At the bottom of the page, you'll see as well, it says, what happened to the invitation? This is a reference to those of you who've used the spikes mnemonic for delivering bad news, which was an invitation. And they say that it really was counterproductive. And so these are extra little pearls at the bottom of the page that you can check in on and learn more about. So I find it a very helpful thing. It's just a nice reminder to have on your screen here. Speaking of screens, mine just changed here, and I'm having a difficult time seeing this. So we're going to talk about the key questions in palliative care. And the first question, after we've done an introduction and we've sat down and we're getting connected, is what is your understanding of your illness? When I talk with pediatric patients, and actually, which can be helpful with other folks too who are living with chronic illness, asking what does a good day look like and what does a bad day look like can be very helpful as well. Or with a nonverbal child, or a child who's not, a person who's otherwise not able to communicate, what kind of person are they? If you have someone who has aphasia or is otherwise unable to speak for themselves, it can be really important to say, this is a person who's very active and who is only happy when they're up moving around. Or this is a person who's, I mean, my uncle has always loved being around his nephews and nieces, and it's really important to him to have connection with his family. Whatever those things are, those bits of information that you can learn about a patient or about a family member, it can be extremely important as you make recommendations. In light of this understanding, what's most important to you, or what would be important to your family member? What are you hoping for? And as we talked about, there's also the question of second hopes. So if you get to that question and it seems to be a dead end, there's a way to get past that. What are your worries? And often I will frame this as in the context of, given the understanding of what your child is going through or what you're going through, what are you worried about? One of my colleagues uses the expression, what keeps you up at night? And I don't like to use that because I don't want to plant the idea that people would lose sleep. Like, oh, should I be kept up at night by something? But it may be helpful in some situations, because for some folks that may be like, oh yeah, that's the thing that's really getting at me. I am just, one of the reasons I love doing this work is because it is so extraordinary to find in my fellow human beings their reservoir of strength, of coping and resilience. And so I love asking the question about, where do you get strength from? And what are your coping mechanisms? And there's a longer conversation we could have another time about understanding coping and resilience, and the internal strengths that we bring, the community and connected strengths that come from being with other people, and then our belief systems, our existential or spiritual beliefs that keep us strong. So I love asking this question. And then the final one, how are you doing right now, and how are you coping right now? How are you doing day to day? And that can be very important, especially if a patient or family has traveled from a long distance, they have other kids to take care of or other family members to take care of. There may be things that we can do in terms of relieving their suffering to make their moment to moment kind of the bottom of Maslow's hierarchy. Well, I haven't been able to eat for the last 24 hours. Well, let's see if we can get you some food. So I wanted to talk about surrogate decision-making and surrogate communication as well. So if you're talking with a family member who is speaking for someone who's unable to speak, then these questions can be helpful. Have you talked with your family member before about a situation like this? The middle one may be the most important, is what would your loved ones say if they could speak right now? This asks the family member to put themselves in the shoes of the patient, and which is a really important thing, because sometimes there can be a difficulty for family members in separating their own wishes from what would be the wishes of the patient. And so to ask them to have the imagination to get inside of their loved one's head and express what would be important for them at that moment. And then finally, this idea of what's important for you as a spouse to this person, or as a child of this person, or a sibling of this person. And the reason I emphasize this is because we have roles, we take on identities within our family systems. So personally, I'm a father and a son and a husband and a brother and an uncle. And each of those roles, being a son or being a father, has a set, in my own mind, a sort of internal idea of expectations about how I'm going to navigate that role. And I want to do the best possible job I can in being a son or a father. I want to be the best brother I can be. And that may mean something different to me than it means to someone else. And there's been a lot of really interesting research looking at what are called good parent beliefs, meaning what does it mean to be a good parent in this situation? I think it can be really helpful. And I remember when I was in Kerala doing my month with Pallium 2 years ago, being with a family member and visiting a family, and they were caring for a woman who had had a series of devastating neurologic events. And I have to say, my own projection was that this woman did not appear to have much quality of life, but her son was immensely and clearly deeply proud of his ability to keep his mother alive with an immense amount of medical intervention. And she was still on earth. And that was his sense of duty to his mother and his duty to his obligations as a son. And it was really powerful. That was the most extraordinary, I mean, the most motivating thing for him. So I think it can be helpful to try to elicit these ideas from family members. What's important for you right now in your role as a family member? So I want to make sure we're, Dr. Sridevi, are we doing okay with time? I know we need to do the case report as well.
We can easily take 10 or 15 minutes more.
Okay, all right. Thank you for that. I appreciate it. And please let me know if we need to truncate. You guys have done, you've been such an extraordinary participatory audience. I appreciate it. So I want to just talk about when we're talking about goals of care, that it can be very helpful to talk about a continuum of intervention. And I'm putting my hands up here to show you specifically because I find it really helpful to use this hand gesture. And I'll do this again frequently with parents, but also with teenagers and with young adults. So first of all, we're normalizing and talking about, so I might say, some families will want to do everything they can to keep their child alive, or some people want to do everything they can to stay alive as long as possible. And they'll take advantage of all medical interventions, medications, ICU care to stay alive as long as possible. And they're kind of over here. And then, and equally loving families and equally thoughtful folks will, at the other end of the spectrum, want to focus on what's going to make them feel good today or feel as best as they can today. And even if that means that their life may be shorter. And there's kind of a space between these two areas. Where would you say that you fall as you think about this for your family member or for yourself? And then I ask the patient to kind of point, where are you on this continuum, as though this were, a sort of number line. And that can be a very helpful way of saying, if someone says, I'm way over here, I want to do everything I can to keep alive as long as possible, puts us in a different place. And someone says, I really want to focus on what's going to make me feel comfortable right now and take advantage of whatever time I might have without the influence or the burdens of treatments. And so I've given a longer explanation or example of how to respond to this. And I'm happy to share the slides so that we don't need to read through this right now. These next areas are also just some specific ways of talking about, for example, if we are discontinuing artificial fluids or nutrition, and how do you respond to these questions? And so I took from another mentor of mine, Sandra Bradman, with whom I worked here in Oakland. And I think there's some really helpful things here to talk about restriction or discontinuation of artificial fluids and nutrition. I like that particularly your loved one is not dying because they won't eat. They are not eating because they are dying. And the withholding or discontinuing feeds and fluids is responding to their body cues. Actually, by the way, I started to say withholding and then shifted to saying discontinuing. And I actually like the word discontinuing much better than withholding. Withholding, much like withdrawing, has a sense of abandonment, and it's one to avoid if you can. Again, related to this, will opioids hasten my family member's death? We're talking about starting with low doses and increasing slowly if needed. This is perhaps a bigger issue for us because we have, obviously in the States, a lot more access to opioids. We have a huge problem in the United States with opioid overdoses. And so there's a lot of concern about folks having a adverse effect from the opioids. So I mentioned emotion. This is a mnemonic. You can find this on the Vital Tips Act as well, called NURSE. This is for us responding to our own emotions as well as to the emotions of a patient in the room. And that was one of the things that came up in the chat box, is when a family is really upset, These are things that can be helpful to remember: naming, understanding, showing respect and support, and exploring. And of course, being aware of your own responses. And so here's what the nurse mnemonic looks like. So you name it. It sounds like you've been worried. It sounds like you're afraid. It sounds like you might be feeling pretty frustrated and even angry about all this stuff that's happening. Just to name it and put it out there can be very helpful. I understand the message that is, say, this. I can see that the context that this emotion is coming out of. You're worried about what to say to your family. State respect or reassurance. Offer support. Would you like me to talk to your family about this, or whatever it might be that responds to what is causing the emotion. And then asking, I see that you're upset. Can you tell me what you're thinking? I will often, particularly if someone is crying in the room, first of all, I will say your tears are always welcome with us, and they are. They truly are. When I am with a family member who is crying, or a patient who's crying, what that tells me is that something that is tender and meaningful close to their heart is coming to the surface. And I have the opportunity and obligation to be with them as much as possible and to bear witness to that. So I say, your tears are welcome. Can you tell me more about what's behind your tears? Thinking about our own emotional response, knowing what your triggers are and preparing for them. I think this would be a wonderful conversation if we had more time to talk about how we all show emotions in group, but I don't think we have time for it today, because I want to leave time for my colleague to go through the case presentation, and then developing practices to discharge and metabolize your own emotional experiences. So with that, why don't I stop right now? Sridevi, is that okay? Is the timing right for that?
Yes, probably. I just made my personal request. This is the last slide. Will be maybe we can spend some time on that, because sometimes that's very important, how to metabolize your own emotions and how far we can take 5.
You bet, absolutely. I'd be delighted. So I'm, the work that we do, no matter what kind of work we do in medicine, even if you're not a palliative care doctor, whatever work you do, you come into contact with people who are suffering, and we have mirror neurons. We came into this work because we care about people and because we want to relieve their suffering, and it must touch us. It should touch us. And so what do we do with those emotions, which can be so powerful, which can be so demanding to us? And so again, I'd love to hear what your practices are. What do you do to discharge, or as one of my colleagues says, to metabolize the difficult emotional experiences that you may come up against? Music, absolutely. Yeah, it's that's really the powerful one for me as well. I have to say, there are certain pieces I go to really help. Talking about it with the team, absolutely. So yes, being connected with your own team in a way that helps you process and again, express the things that are in your own heart. Being out in nature, there's some wonderful studies that have shown how much relief and release we can get just by simply standing and looking up at trees. Journaling, talking to other family members, and letting it come out, and crying with the patient. And I think that is really important, being able to cry with the patient. The only caveat I would put to that is that I think it's important to not put ourselves in the position where the patient or the family members need to take care of us. As my chaplain colleague Will would say, I don't want to be the person who is sobbing the loudest in the room. But I do think crying with the patient, showing our own emotional vulnerability is a very powerful way of recognizing the humanity of the moment. Yes, absolutely. We do cry at times, and there should be no shame in crying. Absolutely. It tells us that we're human and that we care. It is okay. Thank you very much. It's okay to be vulnerable. Absolutely. Absolutely. And let's be honest, in medical training, there's a lot of implicit and sometimes explicit statements that we are not supposed to be vulnerable, that we are to be invulnerable. We are to keep things buttoned up and under wraps. And that is actually be very counterproductive to us over time, I think. I want to mention talking with our team and trying to find whether anything can be done by us for the patient or family. So being productive, being engaged in more work is absolutely a very therapeutic thing to do. The other thing I want to mention is that physical activity can be really extraordinarily important. For some people, it's walking. I have a colleague, she's actually a pediatric oncologist, and she does what she calls memorial runs. So she's a runner, and she will start off and she'll put one or two children in her mind and sort of in her intention, whether or not they're facing difficult illness or they have died. And then she uses the run as a kind of ritual practice to let the energy of her connection with them be processed. Yes, thank you, Dr. Prasad. It's difficult if it's a child or disabled person. The most vulnerable people, the ones who are most feel most vulnerable, are the ones that can often touch that soft front. Yeah. I want to encourage you to have practices to use them. The other one that I find very powerful for me that I wanted to mention is writing notes of condolence, or writing a letter or a card to the family members after someone has died, or even if you've just taken care of them, and to say, and with letters of condolences, there I have a sort of template in my head, which is to talk about my own feelings. So if after a child has died, say I was so sad and have been so touched and saddened by the death of your child, share a memory about the child, about who they were, and something that was that you carry away from them. Talk about how the parents were with them and how they advocated for the child or loved them or showed some particular tenderness with them. And then finally say, I will remember them. I will keep you in my heart. And I find that to be extraordinarily powerful. And I also, if I can, go to memorial services, go to funerals or memorials. I haven't been able to do it as much during COVID, but I find it also very helpful to my own practice to see the community of folks who support someone after a death. So with that, why don't I stop? Is that a good time? Debbie, we can stop here. Is that
Yes.
okay? And then, okay.
Yes,
And,
yes.
and again, I'm happy to share the remainder of the slides. That has some of the, as I mentioned, there's some new research that is available there as well. So I thank you very much again for your kind attention and your wonderful participation. And I'll turn back over to Debbie.
Yeah, so this was a very different session because I think I've heard at least hundreds of communication sessions as a facilitator or as a participant, but this brought in a lot of new aspects which we don't discuss in a routine communication session. So that's really wonderful and a little bit overwhelming. So thank you so much, Tom, for this wonderful session. Very, very different. I'm not just telling it for the sake of telling it, but it was a little overwhelming also at some points. So thank you so much. We'll have a presentation from Dr. Jaswinder, and we'll discuss based on her questions about that particular patient. Dr. Jaswinder?
Ma'am, will the PowerPoint be shared from your side or should I put it on?
Yes, yes. Rajlakshmi? Yes.
Ma'am, if everybody is happy to hear Dr. Tom speak, I'm willing to delay it by another 10-15 minutes because I also found the session very engrossing. So if everybody would rather have Sir go over the slides, we can push this back. This will only take some 10 minutes. And I'm sure we'll have a greater discussion with Sir than with me. So
no, I think based on your questions, we can build up discussions on that, connecting what has been.
Okay, ma'am. Okay, fine. But good evening. I mean, good morning, Dr. Tom. It was a wonderful session with you. And this case presentation that I'm about to do now is about a 52-year-old lady who presented to a tertiary care center with the diagnosis of advanced rheumatoid arthritis. And she had fixed flexion deformities of all limbs and neck. So she actually, this is a case that I came across when I was a postgraduate student in anesthesia. And she was she was undergoing a pre-anesthetic evaluation. And so when I saw her, she already had an inability to straighten or her limbs or to even extend her neck. She was actually crouched into a fetal position, and she had been like that for nearly 3 or 4 years. And she'd had this generalized pain. Earlier it had been limited to her joints, but now she seemed to have a pain all over her body since 8 years. And since she had been in this crouching kind of fixed position, she had not been able to sleep more than 2 hours at a stretch at night. So she was also an insomniac. Coming to the history of her illness, it was an excuse me for that. It was insidious onset of joint pain and swelling 10 years previously. Prior to that, she had no complaints at all. First, it affected both her upper limbs, and then her lower limbs got affected, the hips, the knees, and the small joints. There was, she had a history of trying multiple drug therapies. She had medications for a long time. She had applied a lot of ointments, but then they gave her very limited pain relief, and it used to return usually. Then slowly she started noticing that her limbs were getting stiff, and the duration of stiffness was getting prolonged every day. And over the past 5 years, it had become so bad that she had become flexed into a fetal position. And she required help with all the activities of daily living. Her husband and daughter essentially provided all her regular activities. They helped her brush her teeth, her regular hygiene, feeding also. She couldn't even feed herself. And she gradually kept developing sleeplessness. And now she had no more than 2 hours of continuous sleep at night. And so she felt more like she drifted into sleep on and off during the day, but it was not restful sleep. She did not report any other comorbidities, but she did report that she had extreme sadness. And she had become so desperate, or she had given up hope. So she had given up all medications because she felt that nothing had given her relief at all. She had been referred to the tertiary care hospital in hopes of getting surgical repair of her cervical problem, which had flexed her neck. So that is how she was there. But because she had so many other joint disorders, it was decided that she was like too severe, in presentation to for surgery to be considered an option. Next slide, please. So for her, this case presentation was essentially intended for the session on pain evaluation. And so initially, when she started having her initial presentation of rheumatoid arthritis, it had been a gradual and recurrent kind of pain where it used to come into one joint and then start in another joint, fade off, and then recur again. And usually she found that it was worse when she was moving, but better with rest. At that time, she had found it very burning and an intense kind of pressure on her joints. And as I said, both her upper and lower limbs were involved. And the pain itself was moderate to severe, but at that time, her sleep was not much affected. And it was not like all the joints were affected all at the same time, but on and off, some or the other joint was always painful. And she had tried several oral analgesics and local ointments. Sometimes she found relief and sometimes not at all. So currently the severity of her pain was much worse. She was like any change in her position, whether it was like, or even staying in the same position for more than 20 minutes at a stretch, she used to find that the pain was growing too intense. And it was all over her body. There was no specific, like it was only at her joints. It was in between her joints, also over the long bones. Everywhere she used to feel pain. And when she was at any particular position, it was moderate. But if anybody tried to move her, or she tried to move herself, which was very difficult, it was very severe at a scale of about 9 on 10. And the sleep was definitely affected. And at the moment, nothing at all, no modality had helped to relieve her pain. Next slide, please. So on examination, we had a 52-year-old lady who was alert and oriented. She was deformed. She was poorly nourished. Weight seemed to be about 40 kg. The only significant finding apart from her specific posture was that she was quite pale. Heart rate about 100 beats per minute, blood pressure on a slightly higher range of 150 by 90 millimeters of mercury. And in the respiratory system and cardiovascular system, no abnormalities were detected. But she did have severe deformities, which led to a fetal position. She had a fixed flexion deformity at bilateral hip, knee, ankle, elbow, and wrist joints. Both arms were fixed in adduction. She couldn't kind of lift them off from her chest. And neck was also in flexion, and it was like she couldn't extend her neck at all. Touching her any place at all on her body made her wince with pain. So we put a background pain score of around 6 by 10. And on any kind of touch or position change, a severe score of 9 by 10 was like agreed upon by both patient and examiner. Investigations were significant for a positive rheumatoid factor and an HP hemoglobin of 8.5 gram%. So because on discussion with the involved teams, it was decided that she was quite advanced case. Her disease was too severe to actually benefit from any surgery at any one location. And because of how her body had been affected, things were going to be complicated. So surgery was not offered to her at all. She was only put on treatment with hematinics and some nutritional supplements. She did receive a psychiatry consult, and she was advised amitriptyline 25 mgs at night. And subsequently, because there was no actual treatment that she had looked forward to being offered to her, she was discharged on request. Psychosocial aspects for this patient was that her life was severely restricted because of her movement, like all her joints being stiffened into locked into position. And she felt very depressed because she felt that she was being a burden on her family. Her husband and daughter provided all her requirements at every time. Also, her sleep was severely disturbed. As for the financial aspects, they had land and they were reasonably well off, but then the money was always cyclical. When the produce was good, they were well off. When it wasn't so good, not so well off. She was a very well educated woman. She could she could confide quite easily and quite openly about her feelings. Communication was no barrier for her. And next slide, please. So as I mentioned, the only medication that she was actually could play a role in her pain relief. It was incidentally started by the psychiatry department. That was amitriptyline 25 mgs. And so the main concerns here, of course, the patient still desired to somehow be independent and not be a burden. And however, for the physicians, the main concerns were that we as a team, surgeons and anesthetists, we couldn't really offer her any real curative options. And at that point of time, palliative care was just not explored. It was, I think it was just not considered, or not very, we were not very well aware of the possibilities. That brings to us to some of the communication errors which definitely occurred for this patient and like added to her grief. One thing was that perhaps she did not receive the communication or the advice or education about her disease condition at an earlier stage, where perhaps like her outcome, the severity of her limitations might have been less. And then there was probably some communication gap between the patient and the family, because the family did not, never spoke of her as a burden, but she always felt that she was being a burden on them. And from our side, from the team, which was like trying to figure out some kind of a curative cure for options for her, we did not really inquire into her level of understanding of her disease, how much she really knew. And we did not also inquire about whether there were other sources of pain apart from her physical limitations. And as far as I know, that the lack of available treatment options was not communicated gently. It was kind of unexpected to the family, although expected by the entire team that there was not much that could be done from our side. But the patient apparently had far greater expectations and did not take the news quite like easily. So that will bring us to the discussion slide at the end. In summary, she was a 52-year-old lady with severe advanced rheumatoid arthritis with fixed flexion deformities and a generalized pain of a moderate to severe level. Also, she was depressed. So these are some of the points that we could discuss. Any other points also from the gathering would be quite appreciated. Like apart, I mean, given her condition, what generalized pain, what would be the analgesic of choice? And also we could discuss about the role of antidepressants in chronic pain and other palliative care options that could have been suggested for this patient. Thank you.
Thank you, Dr. Jaswinder. Is it okay if I go back to the main concerns slide?
Yes, ma'am,
Yeah.
please.
Rajalakshmi, no, the main concerns slide. So just an interesting point which is related to today's topic. I mean, many times patients feel that they are being a burden, although the family members don't feel. That's what you share. So that's one situation that we all deal with. They feel that I'm so much dependent, and a lot of distress based on that, because I'm being a burden to the family. So I'd like to hear from Tom how you deal when someone feels that they are being a burden to their family, but the family members they're not even conveying they're okay to take care of the patient. But so how do we communicate that? How do we deal with that feeling of being burdened?
Yeah, it is such a profound and I think a really common experience, a very common worry for many folks. I certainly know it. I can say I've experienced it myself. And so I think my first approach would be to validate it and to say, I can imagine, or I can certainly understand there are a lot of folks who have similar feelings, this worry about being a burden to their family, and maybe explore a little bit. Are there particular ways that you feel that this is true for you and your family right now? And then I would probably say, is it okay if I challenge you a little bit on this or push back on you a little bit? Because what I'm hearing from your family is that they're not experiencing this. And I'm wondering about what's happening in that disconnect there. Your concern is you've expressed really clearly what your concern is. Your family is saying something different and there's a little bit of disconnect there. How do you explain that? And I think I would go at that point, but I would be really very assiduous in wanting to explore the experience of the patient and saying, yes, I understand that you may feel this way. It's a common way to feel, and tell me more about what the source is. And there may be that there's a worry in there that isn't necessarily reflected by the reality, but that worry is a really important thing to be able to get at. And to, again, say, it sounds like it's very important for you to care for your family, and hard for you to feel like they might be caring for you, or some way of sort of pointing out what the deeper connection is that she's also expressing in this as well.
Dr. Sridevi?
Yes, ma'am, please.
Yes, I'm Dr. Sashikla Venugopal. I've been working with my husband, who is a rheumatologist, from 1996. And from the time I saw this case presentation in the morning, it has really been disturbing that, probably when we started practice, we would have seen cases like this. But after that, through the course of these years, we have stopped seeing cases like this. We are able to offer hope or pain relief to even such patients, because there are, as we know, 5% of the patients who present with rheumatoid arthritis are refractory, but even they have hope nowadays, but probably in 2006, not much, not the biologicals that are available now. So I feel the communication errors that she has pointed out is very appropriate, because the lack of appropriate advice at the early disease stage, what usually happens is they expect pain relief instantly. They expect DMRDs to work instantly. So at the time of initiating some treatment, they need to be told that it will take about 4 to 6 weeks for the pain relief to reach a particular state. And what, sometimes we might have to, one NSAID might not work for the other, for one patient. So that sort of a communication is very important. Like she has also mentioned very correctly about the patient's level of understanding of her disease. So these are the things that if they were addressed earlier, I was really feeling so upset after reading this, because I know what sort of a pain that lady must have been undergoing, at least for so many years. So this is where the communication about the treatment options available and how to go about it and what to expect in the course of treatment. So it's a very nice, very appropriate that she's brought out the communication errors here.
Thank you, ma'am.
It's really very emotional, because I was able to empathize with that patient in pain, and it's like I felt so helpless that we let somebody have so much of pain when so much of help is available. So rheumatoid arthritis is actually definitely controllable, treatable if it is found within the treatable in the first 6 weeks or 6 months. So I don't want any more patients to have this in, at least in the coming years. That's what I wanted to convey here.
Thank you, Dr. Shashikala, and thank you for you actually feel for the patient when you went through the presentation. Thank you for sharing that with the group. Tom was mentioning in the chat, how do you hope to grow through this illness? And maybe from the beginning of the session, I was just thinking to regionally translate all these statements into the local language, like I worry or I wonder. I was just trying to translate that language to our own language. How beautifully we can put it in Malayalam or Tamil or Hindi. I think that's somewhere we really need to work. It's easy to read those in English, but sometimes we struggle to put that in local language. I hope all the participants might also agree, because most of the textbooks and the writings are in English. So sometimes we find it really difficult to put that in really good local language. Dr. Dent, sorry, yes, Tom, please.
No, I just really, I'm so glad you made that comment. I think it's such a powerful thing to say, because you're absolutely right. There's all sorts of connotations and denotations that could be very different across languages. It reminds me of, I think it was the German writer Thomas Mann, who says that reading things in translation is like looking at the back of a tapestry, where you can see the pattern, you can see what is intended, but it's clearly not the experience of seeing the front of the tapestry, where you have the textures and colors and shapes that you'd want to see. And so it seems to call to say that within each linguistic tradition or each language, there should be specific work at talking about how to use the words most appropriately and most carefully.
I think everyone is in this group. I have a great big work to do. We can all sit together and bring all these beautiful sentences to our own local language and practice it. Incorporate that into our practice and see how well we can go about it. And maybe we can do something. Whenever we hear sessions, we can share our knowledge or experience in using that in local language, probably. Yeah. Dr.
Can I ask a question, a sort of naive question about your practice too, which is, I find that I've learned so much of my about language and communication from chaplains. And is that a part of your practice that is potentially a place to learn some of this more tender language?
Tom, you were mentioning about learning from the chaplains, right?
Yes, and I don't know how much you all, I mean, in my experience at Pallium, which again was very brief for just 4 weeks that I was there, primary work was social workers and nurses, and I don't actually recall that we had chaplains with us. And so I'm curious if that's part of practice in other places. And that's a group that I find is so good at knowing a language of emotions and how to respond to it.
Yes, we don't have chaplains, but maybe we can rely on our psychologists or people who work with the psychosocial part of it. Maybe they'll have better terms to communicate. There is a question from Dr. Tendril about the same. When the patient feels that is a burden for the family, how to actually respond. We touched upon it a little bit. Dr. Tendril, Tom just mentioned about how to respond. I think this question maybe came before discussion. Thank you.
So how do I'm happy to clarify it.
Yes, please. Yes. Please go ahead.
Yeah, so again, I think my primary goal in that is to really understand why the person says that. What are they seeing? What are they experiencing? And also, what's the emotional content beneath that? What are they worried about in being a burden to the family? And so I would normalize, validate, and explore. These are all emotional cues that they're sending us. And then especially if the other family member is there, as I said, kind of respectfully reflecting back to the patient, here are the concerns that I hear you're saying. Also, your family member is telling us that this is not the case for you. That feels like there's two different views of this. How can we reconcile that? And it may be that it's not reconcilable, but just being a neutral person who reflects back both of those components can be very helpful.
Yeah, thank you. So Dr. Molly has asked, how do we communicate if they have advanced oral malignancy or probably unable to talk?
I'm so sorry. I was saying goodbye to my wife. Could you rephrase the question or repeat it? I apologize.
Yes, yeah. So if they cannot communicate properly because of malignancy in the oral cavity or an NG tube, if they are unable to talk.
Yeah, exactly. This is a wonderful question. If obviously in those situations, if a person can write, that's the first place to go. I think with those kinds of, if they're not able to write and not able to speak, then you can try with yes/no questions as much as possible to elicit things. If they're really not able to communicate at all, again, you need to ask for a surrogate to speak for them. But it may require you doing a lot of hypothesizing and saying, I can imagine you're feeling afraid right now. Is that true? And getting a nod, yes or no. In those situations, I would also, if possible, enlist the help with the resources we have here of a speech pathologist, because often they can put together a communication plan. Typing onto or texting can also be a helpful way for folks to communicate in that situation too. It's a little more laborious, it's time intensive, but it's a way for them to express what's going on.
There is a very relevant question from Dr. Christopher. I was about to ask, it's just there in Dr. Jasminder's question also. How to deal with a patient who got an emotional hurt from a previous healthcare worker? It's a very, very common scenario.
Yeah, isn't it? And it's a tough one because on one level, we want to be respectful and supportive of our colleagues, and there's a little bit of maintaining our the integrity of our group. And I think it's also important to recognize that people can be clumsy with their speech at times, and to say, I'm sorry. And to acknowledge, it sounds like that was really painful for you. I'm really sorry that happened to you. I'm not responsible for it. I see that it was painful, and this is a great moment to first of all acknowledge the pain in it, to apologize if it's appropriate, or apologize on behalf of the team, and then secondarily say, please let me know what are the best ways for us to communicate with you so that we can be as effective as possible. What are the things that will be helpful for you in the future when we're communicating, to avoid moments like this as well. But I think it can be extremely important to validate the experience of someone who has received painful emotional communication within medicine. And unfortunately, we know it happens a lot. Sometimes there are certain subspecialties that can be especially blunt. And I'll sort of roll my eyes a little bit and say, oh, the neurosurgeons, sometimes they can be this way, and they work so hard, and try to normalize a little bit, and they're working so hard, and they're so focused on things, sometimes they miss those moments. I'm sorry that happened. And if possible, to speak to the particular person. I know them to be someone who really cares about their patients and who works really hard, and it sounds like they missed the mark in this moment with you, if you're able to do that. So
Yes,
we can't apologize for our friends. That's exactly right. Yeah.
Yes, and asking again, how can we avoid such situations? That's a good way to start the relationship with the patient. That's a very good point. Yeah. So regarding the patients who cannot communicate, Dr. Moley is telling that's true. Actually, many of them cannot write. So probably we may have to rely on nodding the head or squeezing the fingers for yes and just raising the hands for no. We may not be able to have a long conversation, but probably a few short conversations non-verbally, probably.
Yeah, it's a good point, and I think given that's a lot of limitations in communication, and so you really have to shift your expectations a little bit too, or expand the amount of time, if you can, to spend with that patient. It's going to take longer to get to the important content, because you'll be doing both parts basically if it's just you and the other person. Facial expressions, body language, positioning, things like that are also highly communicative as well, and things to pay attention to. So,
thank you so much. If it's almost time to wind up. I know that none of us want to wind up. Everyone is looking, oh, is it time already? So we had a wonderful discussion, a lot of new learning, although this is like, as I told, we have attended a lot of communication sessions, but this was really, really different. There were a lot of takeaways from today's session, and I hope all the participants will agree to that. Thank you so much, Tom. Even after being not really well with COVID, we could hear your voice a little bit struggling in between. But thank you so much for being with us, and come back soon to Pallium, to Kerala.
I would love to. I'm very eager to get back, and thank you all for your very warm welcome and your collegiality. It's a delight to be with you. Thank you.
Thank you all the participants. Please kindly give your feedback for today's session, and we'll see you next week with another wonderful topic for discussion. Thank you.
Thank you. Thank you, Dr. Tom, and get well soon. And thank you for this. It was a really, really different session, just like how Dr. Sri